We are ready to start. And first of all, thank you for being here today. It is an honor for me to be with you. And it's a privilege to be able to give you information on a subject that's hard to find good information. We're going to have a lecture in two parts today. We're going to speak about the hearing part of this condition first. Then we'll take a little break, and then we'll talk about the outer ear. We'll also have time for questions. And when I'm finished today, I think you will know more about this condition than most doctors. As you have seen, many doctors don't know much because this is so rare. So we will give you information. But first, let me introduce you to my family. These are my three children and their son. Many of you have talked to or emailed with Haley, who is here beside me. Haley is my youngest daughter, and she works with me in the practice. My wife, Julia, is next to me. Then my middle child, who is the son, who has two children, and the third child is due in about 2 months. And then my oldest daughter has two girls of her own. So in our family, we don't have any people who have atresia and microtia. But we do have hearing loss, not in this group of people, but in other people that we know. Now, let me tell you a little bit about me and my experience. Is that I did training starting in 1982 for ear, nose, and throat, and for surgery of the brain and the base of the skull. And I worked at Stanford as the director for 10 years until I went out and started the California Ear Institute. And then in 2004, I began to focus on atresia and microtia. I had done two other parts of my career. The first part was a type of brain tumor that involves the hearing nerve. And the second part is a device called a cochlear implant for children that are deaf. But in the last 20 years, I've focused mainly on this condition. As you may see in a moment, we have some of the most experience of any facility in the world. This is a map that is in our waiting room. And if you look closely, you can see white dots. And that's where patients have come to us from for treatment. We have seen these patients in the last 3 years. So it's very normal for us to see people from overseas. As you know, Alessia, who is with me, speaks Russian, and she is helpful to communicate with you before you're with us, and also she is there when you are with us. And what I'm going to tell you today is based on experience with 4,500 patients who have come from over 75 different countries. Now, our practice, my philosophy in this situation is to find an improved way to do this surgery and to treat your children. In about 2002, I said to my wife the thing that scares her more than anything else. And I said to her, I'm bored. So she wasn't. And she said, what are you going to do? So I changed into focusing on what I think is the hardest condition to treat as a surgeon that we have. And I think, as you'll see, we've made some very good progress to treat patients and how to treat them. So there are several innovations or new things that we have done. And the first one was that it used to be we would fix the outer ear first, and then later we would fix the ear canal. The problem with that is that surgery for the hearing would happen at about 12 or 13 years of age. And that's too late to have the maximum development of hearing and speech. So we were the first to change that. We also have a procedure, as you know, where we can do the ear canal surgery and the outer ear surgery in one surgery. And I described that procedure and did the first one in 2008. We've done about 650 of those now. We also came up with a way to evaluate children to know what the best course of action is. As you know, not every child is a good candidate to have an ear canal, but there are also other options for hearing. And when you're with me in these consultations, everyone will have a plan based on your individual child. Now, you know, we have asked you to send us or bring with you information to help us with that. Some of you have it complete, some of you have it partial. But it's okay. If you don't have everything now, if you get it in a month or 2 months or 6 months, you can email that to me. And we will then either talk by a video conference or we will email you as to what the best plan is. Okay? Now, another is that we do the ear surgery through a very small incision with a microscope and some special tools. Another is that we found in about a third of patients, the junction between the second and the third bones can be abnormal. And no one had ever realized that before. And I designed some prostheses to reconstruct that problem when we find it. So in about a third of patients, that improves the hearing level that we have. And I'll show you some of that in a bit. We also are the first to use a skin graft, which we take from the scalp. I developed a very precise machine that can take a skin graft that's very thin, about a sheet of paper. And it leaves all the hair follicles in the scalp, so the hair grows back normally, and then the skin graft doesn't have any hair on it. We use that for the ear canal. We also have come up with a way to secure the implant so it doesn't move. That was a problem we started to see, so it doesn't come down over time. And then lastly, you'll see we have a prosthesis, which I'll tell you about, which I think is an improvement over what we have used before. So you see there's been a process through the last 20 years of finding solutions to problems and to improving our results. So the purpose of this lecture is so that you know what options you have for your treatment or for treatment of your child, and for you to be informed about those decisions. The important thing for you is for me to be able to explain why, so what options there are, and also what the chance of success is as you make your decision about how to treat this. Okay, so here's the schedule for this morning. We're going to talk about hearing and show you how that works. I'll talk to you about development and how hearing affects development. We'll talk about how to evaluate a child, and then I'll show you the options we have for the treatment of the hearing portion, the Atresia portion of this condition. We'll take a break. And then we'll come back and talk about the treatment of the microtia, or the outer ear portion. I'll show you how that surgery works. And then there are some special considerations and results. Now, I want you to have the time to answer or to ask and get answered any questions that you have. And we'll save our questions to the last part of the morning, probably about 11:30 or so. But if you think of a question, either write it down or remember it so that we can talk about that. Many people are like, I don't know if I should ask this question, maybe it's not a smart question. Almost always when you ask the question, somebody else in the audience also goes, oh, that's my question too. So please feel free to ask this as we go. Okay. So this is my first grandchild, Luke. And Luke was born with normal hearing. But when he was born, his ears were able to receive a sound, but the brain was not developed completely to process the sound. That's normal for all of us. In those first few years, as you talk to them, as they listen to music, as you read to them, then their brain learns to adapt and to use that sound. Now, as I'm speaking to you, the vibrations are coming through your ear canal, causing the eardrum and the middle ear bones to vibrate. And then they're going inside where nerves in the cochlea, the snail-shaped structure, transmit a nerve impulse to the brain. That's what normal hearing does. Here's another view of that. And you can see that the parts of hearing that are important are the ear canal and the outer ear, the middle ear, which includes the eardrum and the middle ear bones, and the cochlea, or the inner ear, and then lastly, the brain. Now, the brain is the processor of the sound that we have. And as you'll see, there are some very important things the brain does with that sound. One is to tell where a sound comes from, the direction. The other is hearing in a noisy place, and we'll talk more about that. But the ear sends signals, as you see here, to almost all parts of the brain. So sound stimulus is a very important part of the development of your children. So it's good to read to them, to let them listen to music, to talk with them, to have them respond to you. That's a very important part of them growing up. Now, this is the normal ear, and this is what happens with Atresia. So as you can see, the inner ear and the middle ear bones are present, but there's no eardrum and there's no outer ear. So the sound is not transmitted into the inner ear. Those of you with children here know that if you get close to them and you speak loudly, they can hear it on that side, because the sound will transmit through the bone to the inner ear. But in a normal everyday situation like this, they would not be hearing the conversation that I'm having. Now, atresia is more common in boys. It's more common in the right ear than the left ear. And it's a situation where about 1 in 10 children have it in both ears. About 9 out of 10 have it in a single ear. Okay? Sometimes these conferences have more children with bilateral or 2-ear atresia microtia, because that's a much bigger impact on their hearing and their development. You also can have an ear canal that partially develops. There's a tiny or a small ear canal that doesn't open completely, and that also can cause hearing loss. All right, so that's how hearing works. Now let's talk about development and what impact that has on children. So the first thing I will ask you is, why do we have 2 ears? One reason might be in case one fails, we have a backup. A more important reason is that 2 ears are needed for some very important functions. Okay? Now, the first one is to tell where a sound is coming from. If you are on a football pitch or you're playing outside in a park and someone calls you, you have to have 2 ears with 2 separate signals coming to the brain for your brain to figure out where that sound is coming from. You may have seen, if your child has atresia and microtia, when you call them, they will hear you, but they don't know exactly where you are, so they have to look around. So that's called directional hearing. Okay? Now, here's what I want to caution you, is I hear all around the world all the time, a parent has gone to their doctor.
I'm very much sorry, can you please slow down?
Slow down? Okay. A parent has gone to their doctor, and the doctor has said he or she has hearing in one ear, you don't need to do anything. And they say, watch. And they call their name and they respond. Okay, that's wrong. Okay, the doctor doesn't know what he or she is talking about. Because with 2 ears, it's very important to go to school, to work, to be in social situations. And the biggest impact that we have is when we are in a noisy place. We've all been in a restaurant where the sound is starting to come up, and you're starting to look across the table, and the sound gets a little louder, and it gets harder and harder to hear. So with two ears, when the sound is very high, your understanding drops to about 90%. But with a single hearing ear, when the noise comes up, your understanding drops to 60%. So where we see a problem with that mainly is in a school or in a social situation. Sometimes children are labeled as slow when they're not. It's a hearing problem. Sometimes we will see that children will become very frustrated when they can't hear and they get angry. Or sometimes they just turn off and go, I'm not going to try anymore. So in that situation, that is a very big impact. In fact, in the United States, we've done studies looking at people who have grown up with a single ear, and on average, they make 1/3 less money than people who have two ears. So it is a challenge. So when a doctor says, he hears with one ear, don't worry, now you know, don't listen. Okay, now, at Stanford University, I taught a course on auditory development. And that course was for a whole semester. And this slide is a summary of that course. So what happens is when we are born, our ears will transmit the sound to our inner ear and to our brain. It's like a seed that gets planted. And the brain starts to learn to process that sound. So your brain will start to learn to tell direction. Your brain will start to learn to hear in background noise. So over the first few years of life, that process starts. The first thing that happens is what we call receptive language. That means when you talk to your child, they can understand the words that you say before they can say them. So that happens in the first 3 years of life. Also, about the same time, they begin to develop their own language. And most children at about a year have 5 to 10 words, and then they start putting 2 words together. And then by the time they're 4 years old, they might have 500 or even 1,000 words. So they learn very quickly in those first few years. And then as they get between 5 and 10, is when the hearing and noise starts to come in and the more complex functions of hearing. What's very important to know is that there is something called a critical period of development. And medically what that means is that when you are developing, you have to have a certain stimulus for you to develop. If you don't have that stimulus, then the system or the brain process will not develop. And if you wait too long, it never will develop. So for example, if patients have not heard at all until they're 30 or 40, they won't be able to learn to speak because the brain has already passed the critical period of development. So it's clear that the earlier that we establish hearing for children, the more normal they will be, and the better they will do with language. So what we like to do is to have hearing in as early as we can get it. Okay? Now, our ideal is between 3 and 5 years is the best time in terms of development for us to restore or to establish hearing. It still works later, but it doesn't work as well as someone who is of a younger age. Okay? Now, one example of this critical period is an accent. So in the United States, I grew up in the southern part of the United States. And if people hear me speak, they can tell that I grew up speaking that way. So that language, that accent will stay with me my whole life, because during my critical period of development, I learned to speak that way. And then after that, it is very, very hard to change it. Okay? This is one paper that shows, it looks at the vocabulary that a child will develop and what their income is over lifetime. And as you see on this curve, lower vocabulary has a lower economic advantage for a person. It's almost 2 or sometimes 3x from the lowest level of language to the highest level. So it's very important for us to talk to our kids, to train our children. In fact, vocabulary is the strongest predictor that we can find of anything in terms of success as they go through life. Okay, so I'll give you a summary. First of all, normal function requires 2 years. Okay. Number 2 is that the development of the brain depends on sound input through the ear. Number 3, early in life is what we want, because that's when the brain develops the best. The earlier we do the restoration of hearing, the better. And lastly, if we miss that opportunity, then we don't have as good results. Okay, so here's a test for you. First question. Can a child respond normally and quiet and still have problems hearing? And the answer is yes. That's the example of the doctor who says in a quiet room, responds to the child and the child responds to him. With single hearing ear in a quiet room, hearing appears normal. Where hearing drops is in background noise. Okay? Number 2, is a single hearing ear a disability? Answer, yes. And number 3, is there a time frame or a time window for us to act? And the answer is yes. The earlier the better. Okay, so that's the only test I'll give you today. So our goal is to provide the best option for early hearing to every ear. Some ears are candidates for an ear canal. Some ears are candidate for a special type of hearing aid. So what our goal is to establish here what the best solution is for your child as we go forward. And ultimately, what we want to think is to think about form, what the ear looks like, and function. Because when we marry the two is when we come to a normal situation, and then life goes on and you can put this issue behind. Okay, everybody okay so far? Yeah, okay. Now let's talk about how we evaluate children. This is a paper that I wrote a number of years ago, about 10 or 11 years ago, where we came up with a way of evaluating children so that we can compare results. Before this paper, nobody really did that comparison. So now it allows us to give you a chance, a predictor of success, and for us to make decisions about what we find in the evaluation. And here's what we do. It's not critical that you understand every one of these, but it's important for you to know these are the things that I look at when I ask you to send the information to us. And they are the hearing level, a hearing test. We look at the outer ear. The more outer ear there is, generally the better the development. The next is an Atresia score, which is based on a CT scan. I'll show you an example in a minute. The fourth one is how much earlobe there is present. Then we look at the jaw. We look at the soft tissue of the face. And we look at whether the nerve on that side is working correctly. Sometimes when a child smiles, if there's an abnormality with the nerve, we'll see that that side does not move as well. And then we know that there are syndromes where the ears can be affected and other parts of the body can be affected. The heart is a common one, the kidneys are a common one, so we look for a genetic basis in this condition. So the two tests that we ask for of you is the hearing test and the CT scan. Many of you sent the CT scan to us before the conference, and I have reviewed and scored all of those, so I'll be ready to talk to you. Some of you have your CT scans with you here, which we can look at, and some of you will get the CT scans later, which you can send to me, and I will look at those as we go. So let's look at each of these tests. With the hearing test, the way the test is done is there's a device placed on the bone, and the device vibrates and transmits sound energy directly through the bone to the inner ear. So we do it from the low frequencies up to the high frequencies. In this graph, the red triangles show that the inner ear is normal. So the hearing nerve function is normal. Next, we bring sound in from the outside with the headphones. And in this case with Atresia, the blockage of sound from no ear canal causes an extreme hearing loss. So we can see the hearing nerve is normal, but what the child is hearing is actually very far down. And to give you an idea of what that is, if you put your finger in your ear, your hearing level is at about the yellow dotted line. So when you have Atresia, your hearing loss is significantly more than if you just put your finger in your ear. Now, this is the CT scan, and what happens is the CT scan takes slices at different levels all through the ear, and we can look at and see what's present in the inner ear. So as you're looking at the screen, if you look at the right side, that's a side that has a normal ear canal. You'll see that coming up right here. The black is the opening of the ear canal. And the other side shows that there is no opening. There are middle ear bones there, there's a facial nerve there, there's balance canals and cochlea. So what we have is a system where I give points to different aspects of what's in the ear. And I require that I look at those scans personally. I look at 10 or 20 of these a week. So sometimes doctors will send me the score, and I say, I appreciate that, but I want to actually see the scan myself. Because it's such an unusual condition, sometimes people don't know how to grade these correctly. But the more points the child has, the better it is. You'll see that you get 1 point off for an abnormal outer ear. So usually 9 is the highest score that you can have. Now, the higher the score, the better chance of success. And patients who have a 6 or above are good candidates for an ear canal. Patients who have a 4 or lower are not good candidates. And people who have a 5 are on the board. So as we look at your scans, I will explain what I see and what the score is as we go. Now, there are a couple of unusual things that we'll see, which I'll go over in a minute. One of them is a tumor that can form where the ear canal should have been, called a cholesteatoma. It's not the type of tumor that will spread to other areas of the body, but it will enlarge and it can be threatening because it can eventually erode into the inner ear or even into the brain and cause meningitis or a threat to life. Now here is a young boy from Korea. So he has, on his hear maps score, his hearing of a 1 shows his hearing nerve is normal. A 6 shows that he has a large hearing loss. He has a grade 3 outer ear. His CT scan showed a score of an 8. He has normal mandible, normal soft tissue. His facial nerve works normally, and he doesn't have a syndrome. So now we can communicate and know that he is a very good candidate to have a combined surgery. And if you see the pictures on the bottom, that is after he's had the ear canal and the outer ear performed at the same time. So what do you do first? Every time we have a conference, we have parents who might have a 3-week-old infant here, and they want to know, what do I need to do? And the first thing you want to do is to get a hearing test, and you want to look at both the Atresia ear and the abnormal ear, or the normal ear, excuse me. Because the normal ear, in about 1 in 4 patients, will have a hearing loss also. So it's important to see what both ears' score is. We like your pediatrician to evaluate your child to see if there are any other abnormalities such as the heart or the kidneys or other issues. And then we determine if they're a candidate for surgery at 2 or 2.5 years of age with CT scan. And then the individual plan, I think, is the most important thing, is to know what's best for your child and why. Every child, it seems, has a little difference in what the best solution for them is. Okay. Now you know how hearing works. You know what sort of effect it has on development. And you know also how we evaluate that. So let's talk about the things that we have that we can use to treat your children to bring hearing to that ear. Okay, and the first one is an implantable device, and there are several of these. The way they work is the devices connect to the bone. Some of them come through the skin and you connect it. Some of them have the device under the skin and an external microphone. And that device vibrates and sends a signal directly to the inner ear. Now, we use that device when people are not a good candidate for an ear canal, for the surgery for an ear canal. It can be a life-saving and wonderful thing for children that need it, but it's not as good hearing-wise as an ear canal. And the differences are here. The implantable device sounds a little bit machine-like. It's not completely natural sound. It also doesn't give you the ability to tell where a sound is coming from. And it also doesn't do well in the noisy place. In fact, sometimes, most of the time, a child will take that device off when the noise gets too high. But it can be much better than not having a device. It's also more expensive over time. The external portion of the device in the United States costs about $6,000 US, and it lasts about 4 years. So during a child's lifetime, there are going to be many of those that are bought. And then the downside of the ear canal is it's a more complex surgery. The bone conduction devices it's a shorter surgery, and it's not as demanding to perform. Number 2 is there are times when we will make an ear canal, and to bring the hearing up to a better level, we will use an ear canal plus a regular hearing aid. About 1 in 10 of our patients will use a hearing aid in the ear canal after surgery because the hearing did not come up to the level that's where we want it to be. And then the third option is to create an ear canal. So what I will show you in the next few slides is how we do that. So our goal is to have the opening, to have skin lining that canal, to make an eardrum, and to allow the mid-ear bones to vibrate and take the sound to the inner ear. All right? Now, there are 4 different scenarios where we will perform the surgery. The first one is after a rib graft. You may know that one of the ways to create the outer ear is to take rib from the chest, to carve an ear, and then to make the ear from that. In that situation, the outer ear surgery goes first, and then the ear canal surgery goes second. Number 2 is there are some patients who have a normal or close to normal outer ear but no ear canal. So in that situation, we leave the outer ear and then we can open the ear canal, make an eardrum, and restore hearing for them. Number 3 is we can do the ear canal surgery first, allow that to heal, and then have the outer ear surgery performed after. We like 6 months between those 2 surgeries. And the ear canal usually comes out behind the small ear. This picture you see on the bottom left right here, that's where the ear canal should be so that it's symmetric to the other side, so when we put an ear on, the 2 will match. And then the last operation that we have is where we do the ear canal and the outer ear at the same time. And this is a patient in the operating room after we finish, before we wake them up, where we have an ear with packing here where the ear canal is going to be. Right, and here is a video of what that will look like. And there's the publication for that. Now, these are my staff. We did our 575th surgery in the fall of last year. Most people, especially people from a long distance, prefer to have the surgery with everything at one time, so they don't have to come twice. That's the most popular. Second is to have the ear canal and then come back later for the outer ear. Okay, now I'm going to show you some pictures from the operating room. So if this bothers you, look down and don't stare at it. You're going to see what I see under the microscope as I'm operating and what we're doing to create that canal. I'll show you a drawing of the ear canal, and then I will show you video of what we do in the operating room. So this child is on their back, their feet are to your right, and their face is pointing away from you. So we now are looking under the microscope, and I've made an incision to expose the area where the ear canal should be. So this is what it looks like. You see, that's the jaw joint, and that is where the ear canal should have been. So next what I do is use a drill that has diamond chips, and we sand away the bone to create the new ear canal. And my left hand is suction, which takes the bone chips away and keeps the bone cool. Next, you'll see that I'm going deeper, and I'm using a smaller drill to get the last pieces of bone. This drill is 1.5 millimeters in size. And here you're just starting to see the middle ear bones. If you can see a curve up at the top, that's the middle ear bone. And then we use a laser to remove the last portion of bone, so the middle ear bones can then be free to move. So that is where the bones are stuck to the bone at the base of the skull. And now we have the middle ear bones free and ready to build an eardrum. You can see when I touch them that they move. The facial nerve is right here. So I think you can see now the middle ear bones can transmit the sound in. So next is to take a piece of tissue which comes from under the skin, over the muscle, and to make an eardrum. The eardrum is about as big as your index fingernail. So we spread the graft over the middle ear bones. And next we use the skin graft to line the ear canal and also to go on the surface of the eardrum. So you can see that the skin graft is taken from the area where the hair comes from. It's very thin, so the hair does not get transplanted, and the hair grows back in the scalp and is normal afterwards. And you see that the skin graft on the right side, I am putting that in position and covering all of the bone and the surface of the eardrum. There's the paper that describes how we do that. And then we put packing in the ear canal that stays for usually about 2 or 3 weeks. And when patients come to us to have the surgery, we ask them to stay with us for 3 weeks if it is just the canal surgery, and for 4 weeks if it is the combined surgery. And during that period, usually week 2 or 2.5, is when I remove the packing from the ear canal. It's a very special day for us because when we remove the packing, the child can hear, usually right away. Now, hearing continues to improve for about 4 or 5 months, but you can tell very early that there's been a significant change. Now, let's talk about the complications that can happen from that surgery. The first one is anytime you do a surgery, you can have an infection. So bacteria could cause a problem. The second is that the eardrum can move off of or move away from the middle ear bones, and that can cause a problem with hearing. Usually it's due to an ear infection that pushes the eardrum. We also see a narrowing of the ear canal. The body sees this as an injury, and it tries to heal it. And sometimes the body will heal too much and cause the ear canal to narrow. Okay? You can see an injury to the inner ear. You can see an injury to the nerve that controls the face. Or you can see some of the skin graft that we put in doesn't heal correctly, and you can lose a piece of that. Now, worldwide, these are the complication rates that we see, and then in our patients, I'm very happy to say we've been able to get those down to a very low level. No surgeon has 0 complications, but the key is to get the complications as small as we can make them. The biggest one, I think, is the stenosis. Many times around the world, people will say, my doctor told me not to do this surgery because the ear canal will close. And around the world, about 30% of the time, that is the case. But with a new technique and with a mold that I make for you before you go home, that you wear for 4 months, our chance now of stenosis is just over 1%. So it's a fantastic improvement compared to what it used to be. So that one is not so much a problem anymore. The one that we see the most common is sometimes later, if there's an ear infection or a trauma, then we can see an injury to the eardrum, just like a normal eardrum. And that can be repaired, but that one is sometimes even years later. And may or may not have to do with our surgery. It may just be part of life for that child. Now, let's talk about some special considerations. Cholesteatoma. That's a hard word. That is a growth of skin where the ear canal should have been. And this is a cholesteatoma that you're seeing on the screen. You see the skin is enlarging. You can see me removing some of it here. And if we leave that, it will enlarge to go into the inner ear, and it can enlarge to go into the brain. Here's one that's gone into the balance canal. Here's one that has gone into the inner ear and caused deafness on that side. Here's a child that had an infected cholesteatoma that started to come through the skin. Now, we will see this cholesteatoma on a CT scan. What's very important is to get a CT scan. Sometimes around the world, surgeons perform outer ear surgery and they don't pay attention to the ear canal. And every year I get patients referred to me who start to have a problem deep to that ear. And before I ever see them, I know what it is, that it's a cholesteatoma. Because that is slowly enlarging and it can cause a problem. This is an example. And I think you can see that there is a mass pushing from under the ear. So there's a tumor that's growing there, and this one caused that ear to be, we had to remove it, take out the mass, and then we had to do a different reconstruction later. So they can be very silent. They can go for many years. We've had patients who had no idea they had a cholesteatoma, and then when they were 22 years old, they went to the emergency room with meningitis, and they got a scan and then found the tumor. So that's one of the reasons we say every child should have a CT scan, even if you're not going to treat anything, to make sure that this condition is not present. By the way, this happens about 3 or 4% of the time. So it's not common, but it is good to know if it's present. Now, this is my daughter's ear. And when she was little, I put a black dot on the eardrum. I think maybe you can see it right there. Okay. So I took a picture, and I waited 6 weeks, and took another picture. And you see how the dot is moving. And then I waited 6 more weeks, and you can see how the dot is moving more. So what that shows you is in a normal ear, the skin in the ear canal grows in a circular fashion, and then it comes to the outside. So it's a self-cleaning system. So we take a cotton swab and clean the outside, but the debris won't build up down inside. When we put a skin graft in, the skin doesn't grow like that. So it will just grow on the surface and it will start to build up. So one of the things we have to do is to clean the ear, usually once or twice a year, to keep that ear healthy. And that's something that usually has to be done for life. It takes about 5 or 10 minutes, but it's something that you need to know as you are considering this. Now, this is an animation of an ear, and you see the eardrum is vibrating as I'm speaking, and the middle ear bones are moving and transmitting the sound energy in. And what we found is in some patients, right here in the middle ear bones, there is a problem. Instead of bone connecting to bone so the two will move, there's a very short piece of scar that causes us to lose energy. And that could be a problem. I think it's one of the reasons surgeons didn't get good results with hearing for many years, because they had never seen this. So what I did was used an endoscope with a microscope on the end and looked very closely at the middle ear bones. This is a normal middle ear bone. You can see that moving right here. Okay, and this is an abnormal one. So if you look here, this is the hearing bone. This is the facial nerve. And then, oops, And as you see in just a moment, when I move the bone, you'll see there's a very short segment that is not connected to the stirrup or to the third bone of hearing. So in just a second, look right here. Can you see that? Okay. So if we didn't repair that, we could have a beautiful ear canal and a beautiful eardrum, and then we get the hearing test and it's no different. So what we've done is we've come up with some titanium reconstruction prostheses to be able to fix that condition. And we like to do that at the same time as the original surgery in patients who have this problem. Okay. Now, I told you about the mold that we make for the ear canal, and this is an example of that. Before you leave, we make a mold for the canal that fits perfectly for your ear canal, and then at night, before bedtime, you put a drop of antibiotic in, put the mold in, and the child sleeps with the mold in. In the morning, you take it out, and you use that for 4 months. So after 4 months, no more mold, but that mold stops or reduces the chance of stenosis a lot. So it's an important thing for us to do.